If being absent, a letter regarding selection of question paper. So you have to prepare a question paper with multiple choice question.
That we shall do, sir, with the help of our friends, those who are our speakers.
And in the meeting, I can see boys of Katihar Medical College. There are plenty attending the class, but they have not applied for examination. That is a sad affair. So tell them they should apply for examination as well.
Namaste, sir. Pradam, sir.
Pradam.
Today's weather is 39.4 degrees Celsius.
Good evening, Dr. Sanjay.
Pradam, sir.
Pradam.
You can start, TP. You can start now.
Sir, are my slides visible?
Yeah.
Yes,
visible. It is very.
Achha. And am I audible?
Yes, fully audible.
Okay. So, sir, I am beginning with your kind permission. May I begin?
Just wait for a few minutes. Sir, before you begin, just a few words from our Dean, Dr. Professor Kamlesh Tiwari, because this is a very important topic, that is approach to adult respiratory distress syndrome. And this is, and we have got this renowned expert in respiratory medicine, Dr. Saurabh Karmakar. And he will share his insights, his view, expertise on the diagnosis and how to treat a patient, how to handle this, especially this very serious conditions or acute conditions of ARDS in the ICU setting. And before I welcome, just a few words from our Dean, Dr. Kamlesh Tiwari.
Thank you, DP. You are doing a marvelous job. You have taken the task with your heart, and your subject is doing very well. I must congratulate you for your effort, sincerity, and planning. Now, I will request you to start the class of today. Thank you.
Thank you, sir. With your blessings, let us join in welcoming Dr. Professor Saurabh Karmakar to the stage. And I'm confident that his presentation will be a very, very valuable learning for all of us. And he will set the guideline how to manage this adult respiratory distress syndrome for we physicians and for respiratory experts. Over to Dr. Karmakar.
Good evening, respected seniors, faculty members, luminaries of the Indian College of Physicians, my dear learners, residents, and doctors who have joined. I am grateful for your presence here. So the topic of my talk is approach to ARDS. I will be taking up one by one the definition, pathophysiology, clinical phenotyping, and newer treatment strategies. So it will be a comprehensive talk of a long duration. So kindly, I request your patience in this. So ARDS is basically a physiology of the lung. It is very frustrating for us respiratory physicians who are managing our pulmonary ICU. It is quite frustrating to manage, and it is basically a lung physiology. So when you are for the PGs out there, when you are admitting a patient of sepsis or pneumonia, talk to the patient relatives in terms of the fact that the patient may be having ARDS. And in ARDS, the lungs are stiff and you have got difficulty in ventilating. It is the most severe form of non-cardiogenic pulmonary edema. ARDS is a clinical syndrome defined by hypoxemia, means a P by F, acute onset hypoxemia, means a P by F ratio of less than 300, bilateral pulmonary opacities, developing due to various pulmonary as well as extrapulmonary causes. Now, if the lung is stiff and the patient is hypoxemia, it can be ILD also. It can be emphysematous COPD also. So that is why we have this terminology of acute onset hypoxemia, which differentiates us from these other chronic conditions. ARDS remains an under-recognized entity clinically because we don't talk in the terms of ARDS. When we are admitting patients from the emergency, it is like we are admitting a case of pneumonia, we are admitting a case of sepsis. But on looking at the APG, on looking at the radiology, we should talk in the terms of ARDS. Therapies are limited and mortality is high, currently in the range of 30% to 40%. But my dear friends, in the Indian scenario, in the public sector hospitals, where ventilator-associated pneumonia, hospital-associated pneumonia, urosepsis, they are major issues. Nosocomial infections are a major issue. The mortality rate of ARDS in the Indian scenario, I believe, are higher. This syndrome has marked clinical, radiological, pathological, and biological heterogeneity. Means a lot of different various groups of patients are there of ARDS. In an autopsy study of patients who died of ARDS, only 45% demonstrated the classical histopathological correlate of ARDS, that is diffuse alveolar damage, with the other 55% patients demonstrating a variety of other pathological findings. Means the cause of mortality in the ARDS at times also resides outside the lungs. Ashbaugh reported the first case of ARDS way back in 1967. So the definition of ARDS has been rapidly changing. The latest definition came in 2023, which I will come to. But in 1988, a formalized expanded definition of ARDS was first proposed, in which it comprised of three parts: whether illness is acute or chronic, whether there are any associated risk factors or medical conditions like sepsis, and it gave a objective score on the amount of lung dysfunction. The lung injury score was given and the average score was calculated, and a value greater than 2.5 was used to diagnose ARDS. Now, a few seconds to this lung injury score. Lung injury score was first of all provided by Murray and Nadal in the classical textbook of respiratory medicine. Murray, unfortunately, he died of COVID, but when we were residents, this was the only score present which correlated with mortality. And when I was a trainee, when I was doing my fellowship in pulmonary medicine, I found this score to be quite useful when we applied it to patients of ARDS whom we admitted in the pulmonary medicine ICU. So there was a AECC definition of American European Consensus Conference definition. It defined ARDS is again the word. Look, even if the definition is changing, the word acute is always coming. In all the three definitions, the word acute was there. Acute inflammatory condition manifested as diffuse pulmonary edema, non-cardiogenic pulmonary edema, and respiratory failure that cannot be explained by coexisting left-sided heart failure. So in the Indian context, when mitral stenosis, mitral regurgitation, rheumatic heart disease is a common entity, then we should always be vigilant in ruling out left-sided heart failure in the patient. It is the most common form of ALI, acute lung injury, characterized by bilateral widespread pulmonary infiltrates with a normal capillary wedge pressure of less than 18 and a P/F ratio of 200 mmHg. For all the PG trainees, whenever you are looking at a ABG or whenever you are looking at a hypoxic patient always calculate the P/F ratio. P/F ratio is also known as Horowitz index. And like, look, the ABG reports vary. We go doing our duty, the oxygen is at 2. Next day we come, it is at 4 liter. Third day it is at 3 liter. So when the oxygen rates vary, the nursing staff or the doctors change the oxygen rate. In the ABG, always calculate the P/F ratio. A P/F ratio or the Horowitz index, it gives you an index of oxygenation, efficiency of oxygenation. It quantifies the hypoxemic respiratory failure present in that individual. And it is quite useful So I always in my daily practice I always use the P by F ratio. I never ask the PO2 कितना है या SPO2 कितना है. Yeah. So again the definition changed in 1994 for the consensus conference of American and European experts who published the definition of ARDS in 1994. ALI was a criteria entity, ARDS was an entity. ALI was defined as when there was bilateral infiltrates consistent with pulmonary edema, left-sided heart failure ruled out, the P by F ratio has to be between 200 to 300 for it to quantify as acute lung injury. And if the P by F ratio is less than 200, then it was classified as acute respiratory distress syndrome. ALI and ARDS, these entities came in 1994. Now, what was the problem in having this ALI
So,
entity?
Saurabh,
Sir,
Saurabh, just a
sir,
minute. Saurabh, just a minute.
sir.
Your voice is breaking. So better off the video.
Okay, I'm switching off the video then.
You off your video.
Doing that. So, sir, I have switched off my video. So
Now it's okay. Now it's okay.
okay, that's good. That's great. So the chest radiograph is subject to variability in interpretation. P by F ratio may vary as per the ventilatory parameters. The diagnostic criteria for left-sided heart failure may be on purely clinical grounds, and it is not always practical to have a pulmonary artery occlusion pressure to put in a pulmonary catheter and measure the pulmonary artery occlusion pressure, or the pulmonary artery occlusion pressure may be higher than 18 mmHg due to intravascular volume loading. Particularly in the surviving sepsis guidelines, they always stressed on high amount of fluids in the initial days, which was detrimental to the patient. For the PGs, there is an entity known as acute cor pulmonale. Acute cor pulmonale may occur in ARDS. In this, the right-sided heart failure, the right ventricular heave, RA-RV pressures may be high. So, because of this entity, again, the definition needed certain amount of modification. Came the Berlin definition, in which they tried to put some numerical constant and they defined the timing to be within less than 1 week with a known precipitant of his condition, bilateral opacities, not fully explained by effusion, lobar collapse, or nodules. The edema should be that respiratory failure is not explained by cardiac edema or volume overload, and they retained this mild, moderate, severe classification of P by F ratio, in which severe ARDS was defined as P by F ratio of less than 100. Moderate ARDS was defined as P by F ratio of 100 to 200, and mild ARDS was defined as a P by F ratio of 200 to 300. The ALI terminology was dropped. So ARDS now at Berlin definition also had certain shortcomings, certain deficiencies, because after 2012, slowly and slowly in the corporate sector in India, HFNC started coming. A respiratory device known as HFNC, it gained popularity during the COVID time. Again, inclusion of HFNC led to certain changes in the definition, and latest definition that we have, the last definition, thankfully, as of now, for the next few years, me maybe sticking to this definition, is that we do not need the patient to be intubated. High flow, if the patient is on HFNC with a flow rate of more than 30 liters per minute, or if the patient is on NIV with a CPAP of more than 5 centimeter water, or if the P by F ratio is less than 300, or SPO2 by FiO2 ratio is less than 315 with a SPO2 of 97%, bilateral opacities, which are confirmed by even a lung ultrasound, CT, or a chest radiography, or in resource limited setting, even PEEP oxygen flow or specific respiratory support devices are not needed. Basically, it has now been restricted to acute diffuse inflammatory lung injury precipitated by predisposing risk factors of pneumonia or non-pulmonary infection, which may precipitate as ARDS. So now we have clinical hallmarks of ARDS. The crux of ARDS is arterial hypoxemia. Arterial hypoxemia occurs in the initial phases of ARDS. Later on, in the late phases of ARDS, we may have type 2 respiratory failure also. Now, there are three phases of ARDS. From the onset of the insult, onset of the lung injury, first phase is the exudative, followed by proliferative, followed by fibrotic phases. These are three characteristic phases of ARDS are there. So in ARDS, there are plethora of cytokine and cellular changes that occur. The main source of damage in ARDS are the alveolar type 2 cells, and alveoli are in the exudative phase, alveoli are filled with a rich exudate containing a lot of inflammatory cells. Otherwise, in a normal bronchoscopy, usually the return is totally transparent. The majority cells are this alveolar macrophages. If we do the bronchoscopy of a normal individual, in a acute respiratory, in an ARDS setting, if a bronchoscopy is done, the return is usually of neutrophils, predominantly neutrophilic return, predominantly neutrophilia in the biopsy, bronchoscopic biopsy sample. It shows some pyogenic infection, and it is the finding in cases of ARDS. One of the earliest manifestation of ARDS, even before hypoxemia, is a transient leukopenia due to the sequestration of neutrophils in the lung microvasculature. So, सबसे पहले we have transient leukopenia followed by decreased oxygen requirement. The radiological changes occur later. So after that, the proliferative phase occurs. In proliferative phase, it usually lasts between first to third week, and most patients recover rapidly and are liberated from mechanical ventilation during this phase. Despite this improvement, many patients may experience dyspnea, tachypnea, hypoxemia. Some patients go on to develop the fibrocystic phase of ARDS, but 7 to day 21 is the golden period when you should try to extubate out your patient from ARDS. So certain patients after week 3 and 4 enter the fibrocystic phase of ARDS characterized by emphysema-like changes and bullets. Believe me, antifibrotics have got exactly no role in this phase, and patients may go on to develop pulmonary hypertension in this phase. And due to the fibrocystic in nature of the lung, there may be pneumothorax, reduced lung compliance, increased pulmonary dead space, and these patients, they always have a significant burden to the community. So this the flow cycle of how typical the type 2 alveolar cells are damaged, followed by release of the vasoactive substances and a plethora of inflammatory changes. Once the vascular narrowing and obstruction occurs of the pulmonary arteries, or hypoxia inducible factor HIF release can lead to a pulmonary hypertension in this ARDS, an entity which is specifically known as acute cor pulmonale. So conditions associated with ARDS may be direct, indirect. Pneumonia is a direct cause, aspiration pneumonia, lung contusion in cases of road traffic accidents, near drowning, or reperfusion injury. Indirect injuries may be pancreatitis, may be one of the ARDS mimics, and these major trauma, multiple blood transfusions, sepsis, these may cause ARDS also. So we have now ARDS phenotypes. Nowadays, for every disease, we are doing phenotyping of every disease. Phenotypes are defined as having similar characteristics that can be observed or detected as a result of interaction of genes and the environment. according to the oxygenation index, the Horowitz index, which I described a while back, it can be divided into mild, moderate, or severe categories of ARDS, or it can be, nowadays it is defined into hyperinflammatory and hypoinflammatory phenotype of ARDS. The residents should be knowing this fact. So there were a lot of studies regarding phenotyping of ARDS. So as a the residents, we doctors, we should always in our free time learn to go through some trials. There were landmark trials on ARDS. ARMA trial, this ARMA trial, it defined that low tidal volume is beneficial for ventilating a patient of ARDS. This ARMA trial was published in NEJM in the year 2000. Alveoli trial told that low PEEP is beneficial in ARDS. It was published sometimes in NEJM in 2004, I suppose. And earlier, they compared a PEEP of 12 versus PEEP of 5, and they found the ventilatory free days, ICU free days, was better in the low PEEP group. This phase was probably regarding the use of statins in ARDS, rosuvastatin in ARDS, and they found exactly no benefit of a statin. Fact was fluid and catheter trial. Earlier, when we were residents, we used to measure the CVP for replenishing the fluids, but it was found in this fact trial that CVP measurement is not robust, is not a robust modality. Earlier, we used to have the CVP manometers, things like that in the ICU. That is not a robust modality. Please do not use that. And low fluid depleted, or I mean, keep the fluids low. Do not over perfuse with fluids, high volume fluids. They are more detrimental than low volume fluids for ARDS. So inflammatory phenotype is more worse. It contains the higher inflammatory markers. एक चीज मैं बताना चाहूंगा कि sometimes we receive patients in the emergency. Okay, usually we receive patients in the emergency. Some of the patients have a rapidly downhill course. We admitted in the night. Next morning they are very sick, very serious. Expire by next day evening, 2 days. So there are certain patients that have a very rapid downhill course. My personal observation is that we always look at the inflammatory markers, always look at the baseline CRP, especially the baseline CRP. If it is high, then it portends a poor prognosis of your ARDS patient that you are admitting to the emergency. So hyperinflammatory have a low mortality, higher ventilatory free days. Hyperinflammatory has a lower mortality and has a higher mortality and a lower ventilatory free days. So now when we receive a ARDS patient, then we will do a phenotyping of the ARDS patient with a oxygenation index of mild, moderate, severe ARDS, and we will have a look at the inflammatory markers of the patient, and we will try to phenotype the patient between a hypoinflammatory or a hyperinflammatory at the baseline. This phenotyping should be done at the baseline. So, multiple latent class analysis was basically a statistical method. In this statistical analysis, what they do is that they try to find out the hidden groups among a certain group of patients. So, higher serum biomarkers, more pulmonary edema and higher mortality is associated with the higher hyperinflammatory type of ARDS. Now, there are multiple studies. Again, retrospective analysis was done. We went back, the researchers went back and studied all the trials, the landmark trials of ARMA, alveoli, FACTT, ARC2, and SAILS. And they found that, again, mortality was higher in the hyperinflammatory phenotype of ARDS and as compared to the hypoinflammatory phenotype, and this difference was statistically significant. Value was statistically significant. So we should try to phenotype using hypoxia severity phenotype, using the phenotyping by exhibiting factors of ARDS, direct versus indirect lung injury. There are certain direct causes of ARDS, there are certain indirect causes of ARDS. timing of onset of phenotype, whether the worsening has occurred very early or whether the worsening has occurred late, as per non-focal or diffuse imaging, as per the relative defined endotypes, biomarker defined endotypes, and hyperinflammatory versus another endotype is there. Inflamed endotype is there. There are several biomarkers for sepsis, like procalcitonin, like presynapsin, CRP. These are the certain biomarkers of sepsis that we use as and when required. Believe me, earlier I used to rely a lot on procalcitonin for diagnosing sepsis and for bacterial sepsis, for diagnosing bacterial sepsis and for phenotyping the bacterial sepsis patient. But over time, now I am relying less and less on procalcitonin. I am just using it only to downgrade or stop antibiotics, and I am not using procalcitonin for the diagnostic or the prognostic value of it. So in the horizon, we have a lot of things in sepsis like genomics, transcriptomics, and proteomics to do the sub-phenotyping of ARDS. Coming to the management of ARDS. The management of ARDS is predominantly supportive care, hemodynamic management, nutritional management, pharmacotherapy, and mechanical ventilation.
What happened, Dr. Karmakar? Dr. Karmakar, अच्छा अच्छा अच्छा, okay. Within a minute, Dr. Karmakar is joining. Just the technical fault. He will be joining. Good evening, Dr. Anupam. Yeah, he's back. Please unmute.
Sir, I am really sorry because of certain technical glitch, and I will again share my slide. Please allow us few minutes for
Okay.
the same. Sir, are my slides visible?
Yes, yes,
Am I audible, sir?
yes, yes. Fully audible.
So I am now switching off my video so that. So I will pick up from where I left. Now the management of ARDS is very important. So in the management of ARDS, always remember, treat the underlying cause. If it is sepsis, optimum antibiotic coverage is important for the management of sepsis. Treat the precipitating cause, ventilatory management for respiratory abnormalities, provide adjuncts to ventilatory support, treat the inflammation and coagulation abnormalities, rule out DIC, send fibrin degradation products to diagnose and rule out DIC if present. The patient may unfortunately have mortality, or if the patient of ARDS survives the ventilatory management, then again what we have is the critical illness polyneuropathy and critical illness myopathy, which we have to manage. So again, coming to that, we treat the underlying cause. Most important is that underlying causes should be treated. If the patient is having chest trauma, polytrauma, rib fractures, then fixation should be done. Appropriate antibiotics. The patient is having cellulitis, surgical debridement. When the source of sepsis is known, both the lung and the abdomen should be considered and excluded as a foci of infection. And prophylaxis against gastrointestinal stress ulceration. DVT prophylaxis should be done. Nutritional support should be provided. Use the gut. Predominantly use the enteral route if the patient is tolerating the enteral feeding, and pain management and cognitive and psychological therapy post-discharge should be done. Physiologic guided management of hemodynamics is very important. So as we see, we should be careful of the right ventricular preload after load. We should assess the left ventricular preload after load. We should assess the pleural pressures when the patient is on positive pressure mechanical ventilation. So now there are two fluid management strategies in cases of ALI. And if there is a positive pressure ventilation, patients, look, fluids benefits as well as fluids may harm. Potential benefit of excess fluids is that they restore the RV preload, augment the cardiac output in the setting of diffuse third spacing, support blood pressure, and restore adequate renal perfusion. But always have a look at the patient's cardiac status. Always have a look at the patient's albumin levels. If the patient is having high hypoalbuminemia, if the patient is having occult heart failure, TCMP, cardiomyopathy, your fluids will do more harm than good. So I would draw your attention to the topic of hemodynamic monitoring of ARDS by critical care echocardiography. Nowadays, we don't put in the pulmonary artery catheter. We should be very proficient with the echocardiographic views, the four-chamber view, the apical view, all the subcostal view, and all the 5 views of echocardiography. We should be proficient with that. And in most patients, so why we need the advanced hemodynamic monitoring? Because gravitation, retention of fluid occurs. More fluids will lead to more edema, acute cor pulmonale, increased pro-BNP, stretching of the ventricles lead to increased pro-BNP. Mind you, use the pro-BNP just to assess whether the patient needs a 2D echo or not. Do not use pro-BNP to diagnose heart failure. But because pro-BNP can be raised even in infections also. So we use pro-BNP, use serial pro-BNP, but do not rely too much on it other than for it to be used for the need of a 2D echo. So in most patients of ARDS, AKI overlaps. So both hypoperfusion with fluids and hyperperfusion with fluids, both are worrisome. So there were guidelines on the management of ARDS published in BMJ. Again, multiple studies have occurred on the restrictive fluid strategy as compared to a liberal fluid strategy. So we always go by the restrictive fluid strategy, do not be too liberal in the fluid management. Regarding the ventilatory management of ARDS, in lung safe study, it was found that application of NIV in patients with severe ARDS was an independent predictor of mortality. Look, there are two modalities of respiratory support before using invasive mechanical ventilation. Either use a HFNC to delay intubation or to prevent intubation in a small subset of patients. If the patient has COPD in the background, if the patient has increased work of breathing, patient has tachypnea, PCO2 retention, then you can use NIV through a mechanical ventilator as, as long as the patient is not having severe ARDS. You can give a trial of NIV in mild to moderate ARDS, but be very watchful of the patients. Most of the ARDS patients, ultimately, they need intubation and mechanical ventilation. Yes, in our resource poor setting like India or in the peripheral centers, a trial of NIV can be attempted under very cautious, watchful observation. So now the mechanical ventilation, there is a ventilation protocol in ARDS network study from Fishman. Table is taken from Fishman's respiratory medicine. The initial ventilatory mode should be volume assist control, less than 6 ml per kg predicted body weight. Keep the plateau pressure as less than 30. Frequency should be between 6 to 35 breaths per minute, titrated with a pH of 7.3 to 7.4. I ratio should be kept at 1:1 to 1:3. The oxygenation goal is always a PO2 of 55 to 80 and a saturation of, mind you, 88 to 94% or 95%. I would not even say 95%. Saturation of 94% is even fair enough. Do not go for a high saturation. Do not achieve to attain 100% saturation. Oxygen toxicity, hyperoxygenation, they have their own antecedent drawbacks. So we should be very careful of that. So for pressure support, you need a FiO2 PEEP of less than 0.4 and PEEP of less than 8 to apply pressure support during weaning. Regarding the FiO2 and PEEP combination, that should be done in the mechanical ventilation. I am coming to that in the subsequent slides. So ARDS net had two types of PEEPs titrated to FiO. One was, in this, you had high FiO2, low PEEP. You did not increase the positive and expiratory pressure much. Another regimen had a higher PEEP and a low FiO2 ratio. So as you see, here in the second regimen, PEEP was incrementally higher as compared to the previous regimen. Now, the thing is that in the alveoli trial, it was said that higher PEEP of 12 or more is detrimental than a lower PEEP of 5. So usually I in my practice do not go towards a higher PEEP. Now when you are setting up the ventilator, always calculate the patient's predicted body weight, which is different for a male as compared to a female, and multiply with a tidal volume of 6, 12 kg, not 8, 6 the patient's predicted body weight and set up the initial tidal volume for the patient. So pH goal should be between 7.30 to 7.45 initially. You should be able to manage acidosis, respiratory acidosis by increasing respiratory rate or until the PCO2 is less than 25. The highest RR that you should go for should be 35. Sometimes you can alter the I's ratio, I is to E ratio to 1:3 also. Do not go for a respiratory alkalosis. Respiratory alkalosis inhibits the respiratory drive of the patient, increase the respiratory rate of the ventilator, so that patient does retain some carbon dioxide, but mind you, the hypercarbia, the permissive hypercapnia, पहले के दिन में concept था कि permissive hypercapnia, that permissive hypercapnia is nowadays, that has gone out of use and it is not recommended nowadays. the patient is a fit candidate for weaning, believe me, a ARDS patient, even if they are responding to your treatment, at least it takes you at least 7 days, usually 3 weeks, for you to slowly and slowly decrease the patient's ventilation until and unless he is a fit candidate for weaning. When you are giving a weaning trial, the patient always look for these warning signs when giving the weaning trial. If you are using pressure support of 0 during weaning, this is equivalent to using a TPs, what we call as virtual TPs, and keeping the patient with a pressure support of 0 during the weaning trial on the ventilator to do an exact assessment of the respiratory rate of patient. Regarding certain slides of our recruitment maneuver is the application of a high level of CPAP or PEEP with the goal of recruiting non-gas exchanging parts of the lung involved with ARDS to be involved in gas exchange. We used to do recruitment maneuvers as residents. In recruitment maneuvers, there are 3 types of recruitment maneuvers: sigh breaths, sustained inflammation breaths, and staircase type of recruitment maneuver. Recruitment maneuver leads to opening of alveoli and brief recruitment. But my dear friends, now recruitment maneuver is not recommended. In the ART trial, alveoli recruitment trial, it was found that recruitment maneuver does more harm than good. Recruitment maneuver was very relevant in the 1980s. In the ICU manual by Marino, there was a separate section devoted to recruitment, but nowadays recruitment as a practice is usually not done for ARDS patients. As we said, that recruitment is likely to be harmful for moderate to severe ARDS patient. I'll quickly skip the slide because there is some paucity of time. I will try to finish in the next 5 to 10 minutes. I will skip this slide again. Complications of recruitment maneuver they are associated with hypotension, barotrauma, and they are even supposed to be ineffective. So now we are unable to do a recruitment maneuver. Patient is having refractory hypoxia. He is on full level of ventilatory support. How do we improve his oxygenation? So for that, now we have got something that we known as proning. So when you are seeing that you have intubated the patient, kept him on mechanical ventilation, you are finding that he is having ARDS. You have started the antibiotics, antivirals in case of viral ARDS. Now you are finding that your patient is still hypoxic. He is not maintaining the saturation target of 88%. What do we do? Now we go for proning. Instead of recruiting, we go for proning. So in proning, the proning first came into picture to the ProSeva trial. I would request the residents that to read the certain landmark trials, Florari trial for HFNC, ProSeva trial for proning in their free time. So this ProSeva trial found the benefit of recruitment maneuver in the patients with the certain limitations. Control group had a higher organ dysfunction and more sicker patient. Study site had a high experience of proning. Okay, when I started the procedure of proning, I was the first one to apply it in the pulmonary medicine department in AIMS Patna. I had to literally stand there, train my staff. We use the pillows. What we did, we took pillows, we rolled up the pillow, तकिया को हमने गोल कर लिया. We taped those pillows to make round cylinders and we made the patient turn around on those pillows to prone the patient. So proning shape of the patient is now always recommended in cases of all more severe to moderate to severe ARDS. It is not that recommended in mild ARDS of patients. So proning does change the elastance properties of the lungs and the compliance properties. Together, it improves that. Proning does help in this way. Okay. So lung compliance is primarily determined by the lung open to ventilation, and any change in the lung compliance leads to a more favorable volume pressure curve. Proning reduces the 90-day mortality significantly in patients with a low P by F ratio. So this is a complicated slide again. Proning does change the gas tissue ratio in favor of the ARDS patient prone, then the patient has better gas tissue ratio. Over time, the gas tissue ratio of the patient ARDS who's prone, it slowly improves over time. So in proning, as you see, the posterior part of the lungs, the part that is behind the heart, the retrocardiac area is the normal lung in which the anterior segments are upper and the posterior segments are lower. Once you prone the patient, the posterior segments are. So, what are the benefits? Carbon dioxide elimination occurs, less cardiac arrest occurs, recruiting the lungs, the lung is recruited, it decreases hypoxemia, hypercapnia, driving pressure, pressure, and improves the right ventricular function and hemodynamics. So as you see, this is a old individual who need to keep close this patient, make sure someone handles the lines of the patient and the ET does not fall out. One of the complications of proning is that sometimes the patient tends to get auto-extubated. Mind you, proning is a very labor-intensive procedure and you have to stand there with the patient and manage at the bedside. So the proning position are changed every 2 to 4 hours. Prone them, deprone them. So the meticulous sequencing of the and the central lines is suggested. So when will you stop proning? Always repeat a ABG after a while. And if there is some P by F ratio deterioration, then do not prone the patient. Every patient of proning will not benefit. So always repeat a ABG for proning the patient. Contraindications to proning, unstable spinal fracture. We do not prone a hemodynamically unstable patient. Regarding other causes of proning, other contraindications, we do not get such patients, but we do not prone a hemodynamically unstable patient. There are other contraindications and complications. I will quickly skip through a lot of complications, but yes, proning in these occur in those centers who are doing a lot of proning of the patient. So, prone positioning has a mortality benefit in patients of severe ARDS. There are multiple trials done in various centers regarding proning versus supine position. Gattinoni also did certain studies. We really miss his presence. Gattinoni is unfortunately no longer with us. He expired a few months back, and he was one of the pioneers of critical care. Most of the critical care, most of the resource poor critical cares, the fundamental simple trials of critical care, they came from Europe, and it was a place in Italy with workers like Gattinoni and all, who did some exemplary studies in critical care. So, what is the mode? There are two modes: volume control ventilation and pressure control ventilation. In volume control ventilation, there is less volume trauma, however, flow is fixed, so asynchrony can occur. Whereas in pressure control ventilation, pressure limit is there. It cannot control the tidal volume, and again, although it prevents flow asynchrony, the patient may need to take vigorous efforts. Initially start with always volume control ventilation, slowly go to pressure control, pressure support ventilation. There's a concept nowadays which is catching popularity. It may be asked to all the residents of intensive care, what is driving pressure? Driving pressure is defined as the ratio between tidal volume and pulmonary compliance. It is estimated by calculating the difference between plateau pressure and the peak, and the airway pressure release ventilation, APRV, which is there in the newer ventilators of it is not there in the market, servo I, but APRV mode that is present in the other ventilators, the more advanced ventilators. So in of Draeger ventilators, it is there. So it allows patients to breathe spontaneously. Single pressure is used to both recruit the lungs and also our ventilation. Mind you, among all the ventilatory modes, airway pressure release ventilation is the APRV mode is the only mode which has shown mortality benefit in patients of ARDS. So early application of in a study between low tidal volume versus APRV, early application of APRV, reduced duration of ICU stay, and mechanical ventilation. The other ventilatory mode of HFOV, high frequency oscillatory ventilation. High frequency oscillatory ventilation was used for all the IP related work, interventional pulmonary related work. It is a type of jet ventilation for interventional pulmonary procedures. Earlier, HFOV or jet ventilation was used. Nowadays, again, it is going out of use. Regarding steroids in ARDS, multiple studies have been done regarding the trial of corticosteroids for treatment of ARDS. We have one of the Meduri protocol. Meduri protocol was one of the important methylprednisolone infusion protocols of ARDS. And what it was said that corticosteroids, when administered during two phases of ARDS, early phase as well as late phase, in these studies, early as well as late phase of ARDS, steroids was used. In the early ARDS, as per this regimen, what we call as Meduri protocol, significantly reduced the ICU mortality. So, as per the CAPE-CORD study, in CAPE-CORD study, they used hydrocortisone in critically ill patients of community-acquired pneumonia. And in this Meduri protocol, both of them did have benefits in patients of pneumonia or ARDS in either of the cases. Regarding muscle relaxants, look, if your PCO2 is high, then you cannot ventilate the patient without using a muscle relaxant. So, muscle relaxants were advocated NMBA's neuromuscular blocking agents, especially when the P by F ratio was less than 120 and especially in moderate to severe ARDS. If the patient has very stiff lungs, if the patient is retaining PCO2, my dear friends, you will need some atracurium to ventilate the patient. You will need a atracurium infusion. NMBA's multiple studies have been done. Review article on neuromuscular blockade ARDS has been done, and it concluded that early administration on NMBA increase the time from ventilator without increasing muscle weakness. But again, if the patient is on steroid, if the patient is on aminoglycoside, addition of NMBA will lead to profound weakness. So do not use the NMBA in the late phase of ARDS. Again, there were certain studies, Accurasis and Rose studies. They've become different. They looked at sedation and light sedation. Multiple studies were there. And surfactant administration was again studied. Surfactant administration is more, it is of more importance, more relevant in the neonates or in the neonatal RDS or respiratory distress syndrome of the neonates or the little infant. But in adults, they don't have much role, and there is no evidence to support the use of antioxidants or immunonutritional support in ARDS. Inhaled nitric oxide, although inhaled nitric oxide is beneficial, I am sorry to say that I have got no experience with that, so I will not be able to give any much insight. Inhaled prostacyclin, it also produces improvement in oxygenation, but again, inhaled prostacyclin is still not available in India or it is very costly. Inhaled prostacyclin has been utilized in patient. It has a beneficial effect when in patients of interstitial lung disease with severe PH. Certain CTDs, they are associated with severe PH, severe pulmonary hypertension, and it is the pulmonary hypertension that leads to a poor prognosis in those patients of connective tissue disease, ILD, and inhaled prostacyclin helps them. But again, these are very costly agents and likely not available in India. ECMO came into use after the COVID. Till date, millions of children, millions of patients have been taken on ECMO. It provides the support of oxygenation. The entire blood is taken out from the circulation. We had taken one patient of ECMO, one patient of ARDS on ECMO. There was some initial benefit. Believe me, ECMO is something which Caesar trial told the benefit of ECMO, but again, it is a very labor intensive, very costly modality. It is usually not available in other than the metropolitan cities. But yes, ECMO, it is of benefit. The benefit of ECMO is known, and ECMO is something whose benefit, especially in viral ARDS, refractory ARDS, when the patient has white out lungs, it does benefit as per the Caesar trial, and it reduced the length of stay, and hospital length of stay was reduced in ECMO patients. Death and severe disability was also reduced in ECMO patients. There is another entity known as ECPOR, extracorporeal carbon dioxide removal, especially in patients who have acute hypoxemic respiratory failure. In ECMO also, you can increase the sweep rate and manage the carbon dioxide. It's not necessary that ECPOR is only needed for managing the high carbon dioxide present in patients of ARDS. Even ECMO with a high sweep rate can take care of the carbon dioxide. So in the concluding slide, ARDS has high mortality, hence early diagnosis is of paramount importance. Know when your patient of sepsis is going to ARDS. Know when your patient of pneumonia is going to ARDS. Know when your patient of blunt trauma chest trauma is going to ARDS. Invasive mechanical ventilation is the treatment of choice along with other supportive measures. Do not play with HFNC or do not play with NIV when you have certain doubt about its efficacy or when you feel that the patient may deteriorate. Steroids can be helpful in early stage. Recruitment maneuvers and prone positioning helps. Recruitment maneuver does not have that much relevance nowadays, but definitely prone positioning has been shown to have benefit without doubt, and always conservative fluid strategy has to be applied to ultrasound. Look, for all the residents, be familiar with the FALS protocol, Blue protocol, and the CSAM protocol. CSAM protocol is for a cardiac arrest, but Blue and FALS protocol, it is used for seeing the lung oxygenation. There are 7 principles of lung ultrasound. It is a separate topic altogether, but always look for IVC diameter, the contractility index of the IVC, replenish fluids as per the contractility index of the IVC. So it is the lung ultrasound should be known by all of you to look at fluid replenishment for your patient. So I thank you for your listening, and I would be happy to take questions if there are.
So, congratulations, Dr. Saurabh, for your comprehensive deliberation on approach to adult respiratory distress syndrome, starting from the definition to the phenotypes to the diagnosis to the guidelines, approach, preventions. Now I request our PGs and other delegates to post their questions on that chat box so that our learned expert can answer your questions. So one of the question from Dr. Neha Kumari, why do some patients with ARDS develop progressive and irreversible lung fibrosis?
Dr. Neha, the thing is that first, your patient of ARDS has survived. Okay. The best news, the good news is that a patient of ARDS has survived. So that is the best part of it. In the fibrotic phase of ARDS, again, due to all the lung injury that is occurring, fibrous tissue, it closely mimics the post-COVID fibrosis. We have seen so many cases of post-COVID fibrosis. This process closely mimics it due to the presence of fibroblasts. If the patient has high level of TGF beta, transforming growth factor beta, fibrosis will occur. And fibrosis leads to fibrocystic changes. Again, no specific treatment modality has been described for this. It is basically rehabilitation, management of through physiotherapy, mobilization, proper nutritional support, long-term oxygen therapy if the patient is hypoxic. As of now, lung transplant is not that much developed a modality that we will advise that. But let's see how this modality slowly picks up in India. As of now, we do not recommend that modality so much among our ILD or lung fibrosis patients.
Again, Neha, difference between signs of respiratory distress and failure.
Respiratory failure is a definition. Okay. Always look at the respiratory rate of the patient. Mind you, a high respiratory rate is the first sign of respiratory distress, impending respiratory failure. Dr. Neha, patient ka respiratory rate standing behind the patient with the patient not watching you, always measure the respiratory rate of the patient. A respiratory rate of with a effective HFNC therapy, effective NIV therapy, effective low flow oxygen therapy, the respiratory rate of your patient should settle down. Respiratory failure is a definition. You need a ABG for that. There are 4 types of respiratory failure. Type 1 respiratory failure when hypoxia is there. Type 2 respiratory failure when hypoxia as well as hypercarbia, respiratory acidosis is there. Type 3 that occurs in post-operative patients due to basal atelectasis, due to collapse of the lung, and type 4 that occurs in sepsis. So there's a fundamental difference between respiratory distress and respiratory failure. Respiratory distress is something a clinical feature. Okay, clinical feature, whereas respiratory failure is basically a ABG based definition of your patient. All patients of respiratory distress may not go into, mind you, there are certain causes of tachypnea. They are like metabolic acidosis. Okay. So if a patient has metabolic acidosis, then patient will be tachypneic. Okay. But then again, the treatment is not respiratory. So ABG is always needed. If you receive a patient of tachypnea, always look for in the ABG, look for bicarb also. After you have looked for the PO2, PCO2, lactates, these are very important. Okay. Lactate, among the biomarkers of sepsis, lactate is very important. Okay. The baseline lactate is important. With effective fluid therapy, give the patient fluids. With effective fluid therapy, the lactate clearance, lactate washout should occur. But again, if the patient has liver failure or if the patient has disseminated malignancy, that is type B lactic acidosis, then that is not, I mean, the lactates, they are not reliable.
Is there role of high dose of steroids in this ARDS?
No, high dose of steroids, by high dose of steroids, I mean pulse therapy. Pulse therapy other than immunological cause. Look, there are certain ARDS mimics, okay, or there are certain differential diagnosis of ARDS. There is a condition known as acute interstitial pneumonia, AIP. There is again acute eosinophilic pneumonia. Okay, so these are the acute eosinophilic pneumonia, acute interstitial pneumonia. These are the or diffuse alveolar hemorrhage. Okay, post-viral DH. So predominantly, these are the immunological phenomena that may present as ARDS. But again, pulse therapy, high dose steroids, because in India, infection, hospital acquired infection, ventilator acquired pneumonia, hospital acquired pneumonia, urosepsis, these are predominant issues. So pulse therapy is not recommended nowadays in cases of undiagnosed immunological disease. At most, if you have ruled out infection, you feel the patient has certain immunological disease like acute exacerbation of ILD. If it is acute exacerbation of ILD, you can prescribe the patient 1 to 3 mg per kg of methylprednisolone or cryptogenic organizing pneumonia. So don't give pulse, but yes, 1 to 3 mg per kg of methylprednisolone subsequently tapered after 5 days can be used. How to differentiate ARDS and CHF clinically? For the look, clinically, you should always look at the JVP. You should look at the hepatojugular reflex. Cor pulmonale can present in patients of long-standing respiratory failure, long-standing respiratory disease. For cor pulmonale to occur in COPD, or you need at least 10 years of chronic hypoxemia to be there. So you look, you in the emergency, you receive a patient of respiratory failure. कि डॉक्टर साहब पेशेंट की सांस फूल रही है. CHF के लिए you need orthopnea, history of paroxysmal nocturnal dyspnea. Press the lever, press the right upper quadrant of the patient. Okay, if you see a hepatojugular reflex, if you see that JVP is raised, that is more a case of CHF. But I tell you one thing, the word CHF is not used nowadays. The word used is HF, heart failure. So that is heart failure. For ARDS, antecedent history of fever, antecedent history of burning micturition. Subsequent to this, the patient is having now in worsening tachypnea, worsening tachycardia, then that is ARDS. So you cannot, so in HF, you will not have fever. Look for fever, spiking fever, okay? Things like that. In a patient of LRTI, look for purulent expectoration, look for burning micturition, okay? For this, how CKD modify the outcome of ARDS. Look, CKD is present in a majority of the patients of hypertension, diabetes. They may have chronic kidney disease. In chronic kidney disease, uremia is there, okay? Because of this uremia, because of the high urea is the immunosuppressant. So high urea, look, always ARDS outcomes are worse in diabetics, hypertensives, CAD, CKD. It like COPD. These comorbid conditions worsen the outcome of ARDS. ARDS can cause heart failure. Early phase में it cannot cause heart failure, but there is a no. Look, sepsis में दो phases होते हैं. Early phase of sepsis, late phase of sepsis. Late phase of sepsis में you have myocardial stunning, left-sided heart failure, focal hypokinesia. You will have coagulopathy also. Sometimes you will receive those patients जिसका INR. So you are believing sepsis, look at INR. If the INR is raised 1.6, 1.4, 1.8, then believe me, my dear friend, high likelihood is that the patient has late phase of sepsis. We receive patients of lung cancer. We receive patients of pulmonary TB, but concomitant bacterial sepsis is there. Always be aware of sepsis. Okay, COPD patient may have sepsis. Most patients of pulmonary TB die because of sepsis. Most patients of lung cancer have concomitant sepsis when they are presenting to us for the first time. Any role of ARDS causes heart failure in the late phase, say 3 weeks, 2 weeks after that. That is why it is important to restricted fluids, okay? Any role of pro-BNP in differentiating HF and ARDS. Look, I will tell you again, do not diagnose heart failure with pro-BNP. Pro-BNP is raised even in infections. Always, there is a question in emergency medicine कि क्या कहते हैं, describe your approach to a patient of acute undifferentiated dyspnea. So in acute undifferentiated dyspnea, you send a pro-BNP also. A high pro-BNP is an indication for getting a 2D echo done. With time, with optimal diuresis, pro-BNP tends to settle down. But do not use pro-BNP as a diagnostic of heart failure. It can suggest heart failure, especially since the patients have concomitant sepsis also. We use the ultrasound, okay? Use the lung ultrasound, look at B lines. If B lines are lung rockets, if lung rockets are present, the patient has pulmonary edema. If the patient does not have those lung rockets, then look for PLAPS. In PLAPS, pneumonia is one of the causes, things like that. Use the lung ultrasound for looking at the lung and for looking at the IVC, whether we need to give the patient fluids or we do not need to give the patient fluid. Is early muscular dystrophy may prolong the recovery? Yeah, will we give Look, again, neuromuscular aging paralysis should be administered in early ARDS if you are unable to ventilate the patient. If the plateau pressures and are high, then and you are unable to ventilate, or if the patient is retaining PCO2, then again neuromuscular paralysis is indicated, but go by a step-by approach. After doing our IP work, interventional pulmonary work, our target is to extubate the patient within the next 12 hours. If you want an early extubation, do not give the patient neuromuscular paralytic agents. But if you feel that a patient has very stiff lungs, P by F ratio is very less, you are ventilating the patient, but the peak pressures are rising, hemodynamically the patient is stable. Observe the patient. Repeat an ABG. If ventilation goals are met, patient is not retaining PCO2, fine. Do not administer paralysis. Sedation will be fine enough. We use 7 ml per hour fentanyl to sedate the patient when the oxygen requirement is not very high. Okay. After that, if still we anticipate the patient will need prolonged mechanical ventilation, we add midazolam onto it. More prolonged mechanical ventilation, we use atracurium infusion, but in a very cautious manner. How long we wait on spontaneous T-tube before extubation? Calculate the RSBI. Okay. Patient should not have fever. Patient's potassium should be corrected. Patient should be totally conscious. His cardiac function should be all right. Vasopressor support should be hardly 1 or 2 ml per hour, although I wait for the vasopressor support to be tapered off. Then calculate the RSBI, rapid shallow breathing index, respiratory rate divided by the tidal volume. On the ventilator panel, you have the respiratory rate. That is why we do not use the TPs. We use the virtual TPs. We keep the ET in situ, attach the ventilator, keep the pressure support 0. The ventilator panel shows us the tidal volume, respiratory rate. If the respiratory rate is, say, 28 and the tidal volume he is generating is, say, 400, then 28 divided by 0.4, it gives us the RSBI. If the RSBI, usually it's at most 30 minutes, you observe the patient. If the RSBI is less than 105 for 30 minutes and the criteria are met, which I told you, we extubate the patient and we apply NIV immediately. We always look for post-extubation respiratory distress. NIV has a better prophylactic role than a therapeutic role. Once post-extubation respiratory distress has set in, look, there is a 10 to 20% chance that your patient will get reintubated. However, if he is not, if post-extubation respiratory distress has not set in, once you are extubating, apply NIV. It is always safe for the patient. And watch for and repeat a ABG, say, after 30 minutes. Okay, he should not have paradoxical breathing. Paradoxical breathing should not be there. Secretion should not be there. So these are the things. When respiratory distress, patient becomes restless in the ICU. Which situation should be? If they look, एक चीज जान लो हमेशा, or a patient on NIV or a patient on invasive mechanical ventilator should always be comfortable. He should not be fighting the ventilator. He should not be thrashing around. If your patient is uncomfortable, always look out for the reason of your of his discomfort. Is he not being adequately ventilated? Is he not being adequately oxygenated? Is there certain HME secretions have stuck in the HME and proper ventilation is not occurring? Which sedation preferred using minimal respiratory depression? Well, usually midazolam works fine enough. Midazolam works fine enough, but always go for less of midazolam, especially if the patient has CLD, some liver dysfunction, then you cannot use midazolam. Less of midazolam, more on Fenta. Use Fenta for its sedation property. But again, it has got its own limitation. So ultimately, fentanyl is the analgesic. Ultimately, midazolam is a sedative. So midazolam we use across the board. That is the standard thing to use. I would be happy to take any questions if there. Else, if barotrauma occurs to high pressure ventilation, should be take. Look, by what I understand from your barotrauma is that patient may have a pneumothorax, pneumomediastinum. No, my
DP
dear.
Singh sir, you are mute.
Oh.
No.
DP Singh.
Sir, my audio is on.
No, you are audible. You are audible. DP Singh sir was mute.
So just one last question, then I will stop. So what I understand by Dr. Sharma, what I understand by Dr. Sujit ki barotrauma, that patient may have suffered a pneumothorax or a pneumomediastinum on a high pressure mechanical ventilation. Reduce the PEEP to 3 or 4. Always reduce PEEP. PEEP to 3 or 4. Rule out pneumocystis carinii pneumonia. Rule out COVID. These things can cause pneumothorax, pneumomediastinum, and my dear, no surgeon will operate in a patient who is already on mechanical ventilation. The only management of, if the patient has suffered a pneumothorax, believe me, if the pneumothorax has occurred on mechanical ventilation, you have to immediately insert the ICD. Okay, insert the ICD and see what surfolio grade of air leak that patient has. Usually it is surfolio grade 4 of air leak. So first, you stabilizing by conservative measures. CVTS surgeon does not usually in the non-corporate sector setting, they usually wait for the patient to be stabilized, their air leak to close, their pneumomediastinum to resolve before they take a patient for surgery.
Thank you. Over to Dr. Sanjay Kumar for closing remarks.
Very nice presentation by Saurav as usual, and he explained the things in a very nice way, right from the very beginning. The different definitions and the definitions that is in offing, that is the inclusion of HFNO. So, and he jolly well classified the phenotypes and how to manage things. The last slide, that is the take-home message, is the most important thing to make the summary of this very important and very vast topic, that we will have to diagnose the cause of the ARDS, whether it is a pulmonary cause or extrapulmonary cause, and then you will have to manage the cause as well. And the thing that he has described very well about the lung safe ventilation, that is the low volume, low pressure ventilation to start with, and how to wean the patient. How to wean the patient, it is also very important how to wean the patient, because putting the patient in the ventilator in the ARDS situation is done, and sometimes we get very much difficulty in weaning him out. And one part of that we always miss or we don't care is about the nutritional part, because nutrition is also very important, because the patient have very high calorie demand in that situation. So all these has been explained very well by the Saurav. So many thanks, Saurav, for your brilliant exposition of the topic.
So thanks for the opportunity, providing the opportunity.
No, so very nice.
So thanks everybody and good night.
Good night, sir.
Thank you.
Good night, everyone.
Thank you.